Hi, everyone, and welcome to all of you who are able to join us. My name is Kelelaye Emiru. I serve as Vice President for Center for Professional Strategic Alliances here at the National Minority Quality Forum. I'm super excited to have this conversation. It's powerful and timely, and it's challenging really the status quo and reshaping how we think about healthcare. We've titled it When Payment Systems Violate Natural Laws of Life, aligning ESRD policies with biology to ensure optimal kidney care. And really, this isn't just another policy discussion. It's about life, it's about biology and justice. So let's get into it. I actually want to begin with a simple but profound question that we at NMQF have been thinking about for some time. It's Are we designing healthcare to work with or against the natural laws of life? And if we're able to level set, let me lay out some facts that are important to this conversation. It's important to know, despite spending over $12,000 per person on healthcare annually, the US ranks last in terms of access and outcomes among high income countries. And according to the National Kidney Foundation, an estimated 37 million American adults, and that's 1 in 7, live with chronic kidney disease. And nearly 90% of it, that's 90% of these patients are unaware of it. Diabetes, high blood pressure are the leading causes, but the burden of this disease is not shared equally. So if you're a Black or African American individual in this country, you're more than 3 times likely than white individuals to develop end stage renal disease. So this isn't just a coincidence. And these statistics are more than just numbers. They are the real impact and deeper ongoing inequities that we deal with in terms of kidney care. So it's evidence that our healthcare system is not working, is a disorder to it, and it's actually one that violates the fundamental natural laws that we talk about sustaining human life. So today's discussion will explore how these natural laws inform the physical laws framework and how that can help us reimagine healthcare, redesign the payment policies and payment systems like the Medicare ESRD bundle to better serve patients, especially in high-risk Black, Hispanic communities that are disproportionately blunting the impact of chronic diseases. So we have 3 phenomenal guests with us, all of whom are co-authors of this powerful ESRD blog article that's actually now live on Health Affairs. One that's a national leader in helping us reimagine the future of healthcare, and the other 2 are frontline nephrologists delivering exceptional care and bringing real-world patient perspectives that we need in this conversation. So please read this Health Affairs article. You can find the link below. We'd love for all of you to engage, comment, and participate and be part of this discussion. So without further ado, let me introduce my guest. We have with us Dr. Gary Puckrein, who's president and CEO of the National Minority Quality Forum and really the architect behind the physical laws framework. We've got Dr. Janice Desir, a practicing community nephrologist, physician advisor, and manager of peer-to-peer services, and co-chair of our Nephrologists for Equitable Kidney Care. We also have with us Dr. Frida Fisher, who is a quadruple certified physician in nephrology, internal medicine, pediatrics, and who's also a social media influencer. So Dr. Puckrein, let's dive right in with an understanding of just what is the physical laws framework and why is it essential for reimagining healthcare delivery here in the U.S.?
Well, Kayla, thank you so much, and I'm pleased to be on the panel with these noted nephrologists. The physical laws framework. So in 1943, one of the founders of quantum mechanics, Edwin Schrodinger, gave a public lecture called and turned into a small publication called What is Life? And at the time, he was trying to understand how hereditary material was being passed from one generation to another. And he thought it had something to do with physics and chemistry. And he that lecture led to Crick and Watson focusing in on DNA, and led to that discovery, and then later on molecular biology. So he set the stage. One of the things he said in that lecture is that life is bound by certain physical laws. The way in which atoms bond, the way in which cells work, the way in which molecules work. And his understanding was that that was the difference between a living object and an inanimate object. And much of contemporary science, systems biology, thermodynamics, complex systems, all of those are built around those physical laws and how they operate. But in the world of healthcare policy and financing, we don't use those physical laws. It is as if policymakers, payers believe that they can put policies and financing models together that stand outside of those physical laws. The consequence of it is, yes, they can do it. We have free will and we can do that. But when you do it, you're necessarily going to create poor outcomes because those physical laws are immutable. You can't change them. You can't. You can learn from them. You can figure out how to improve life from them, but you can't ignore them. And in fact, I would argue that as we get a deeper understanding of those physical laws, we acquire more and more freedoms. And so our future is really bound to those physical laws. And so in this health affairs series, there are 15 different blogs that we'll be doing over the next several months. This one is on the ESRD bundle. And we think that what we're beginning to raise the question is, if your healthcare policy and financing are not following those physical laws, what are the consequences to the patients that you're treating? And our argument is that you cannot deliver quality care outside of those physical laws.
Wow. Thank you, Dr. Puckrein. That was excellent foundation understanding of physical laws framework. I know it's a complex issue, but how does the physical laws framework help us diagnose when there is a breakdown systemically and failures? And can this be measured in terms of the biological disorder that we see manifest, especially in historically under-resourced and underserved communities?
Well, the science is allowing us to do incredible things. So my doctorate is actually in history. I studied classical medicine, Hippocrates and Aristotle and Galen and bloodletting and leeches. We're far removed from that. We are at a place now where we've opened up the book of life back to Schrodinger in terms of understanding some of the genomics that make our life work. We also are having a deeper understanding of the processes that make life possible. One of the challenges that we have with the ESRD program, which is government finance, it started back in the 1980s when dialysis became available. Government came in because people couldn't afford to be on dialysis. But it's hurt innovation. Renal replacement therapies are not where they should be. And so it's not just the ESRD bundle that's the problem. The problem is much deeper because it's hurting our ability to innovate. I'll leave it to the physicians to talk to you about the importance of the kidney in terms of life functions. But the point of the matter is, as we enter in deeper into the 21st century, we have to get our healthcare policy and financing aligned with those physical laws. Legislators, executives who think that they can ignore those laws and provide quality care are really misleading you. That the future is for us to drive closer and closer to those laws and make sure that as we are delivering healthcare, we are aligning very closely with them.
Well, thank you. So let's now connect this scientific framework, if you will, to real policy. Specifically, I know you mentioned the End Stage Renal Disease Payment Bundle, ESRD payment bundle. And our health affair article as well points to it in terms of how this policy violates the biology and as a result undermines patients' outcomes. So before we dive deeper, I want to take a quick minute to explain what we mean by the ESRD bundle, because it's central to today's conversation. So the End Stage Renal Disease Prospective Payment System, which is often called ESRD bundle, is how Medicare pays dialysis centers for treating patients with kidney failure. So instead of paying separately for each drug or lab test or some sort of assessment or service, Medicare combines or essentially bundles all of those costs into a single payment per treatment. So while this was intended to control cost and simplify billing, as CMS states, it has also led to unintentional consequences, which is what we're talking about. So when life-sustaining medications or innovative therapies get bundled without the additional reimbursement, we know access is going to be impacted, especially for newer or more effective treatments. And as we'll discuss today, when payment system ignores the reality and the biology, it can disrupt balances for patients' survival. So this is why understanding of the bundle is important, but it's not just about economics. It's about whether patients can get what their bodies need and follow the natural order in this case. So Dr. Puckrein, coming back to you one more time, where do you see the most direct breakdown of biological order violations of this principle?
So if I can stay in the world of ESRD and the ESRD bundle, the challenge is that innovative medicines are finding it difficult to be made available to Medicare beneficiaries through the bundle. Now, this is not absolute. In the case of Epogen, where we were trying to manage anemia, and it was being there was a drug called Epogen that was being overprescribed. The bundle sort of reinforced what FDA was saying about limiting access or lowering the amount of Epogen that was being prescribed to patients. So it is not wholesale, but the point is that when you're not prescribing correctly, you are allowing the body chemistry to change. Mm-hmm. Those changes in body chemistry lead to symptoms. Some of those symptoms can lead to surgeries to be resolved. Some of them can become life-threatening. And that's the point, that you don't want to put a policy in place that in its application raises patient risk. So we can talk a whole lot about financial risk mitigation and how the bundle works for financial risk mitigation, but it's not working for patient risk mitigation. And we have about 750,000 people who are on dialysis. And the idea that we're elevating their risk for poor health outcome cannot be classified as quality medicine.
All right, let's continue with some reflection. Dr. Frieda, to you, what inspired you to write this piece? And as a co-author of this article and a practicing nephrologist, how are these violations, if you will, affecting your patients?
Thank you. I was inspired because I see that there really is a knowledge gap. When we think about policies and the bundle, you think that the priority should be the protection of the patient, right? What's in the best interest of patients, their health, their convenience, their well-being. But this is one situation where what's going on with the medical bundle is completely against what is in the best interest of the patients. And I find that in different conversations that I've had with lawmakers and with policymakers, a lot of times they really don't understand. And that is why it's so important for clinicians and people like me, physicians and nephrologists, to work with the people making the policies, because even though some things may be one size fits all, hey, let's cut and paste, that's not the case when you're dealing with real human lives, with real patients who are being negatively affected and not having the opportunity to take advantage of the best technologies that can be life-saving.
Thank you, Dr. Farida. You've also shared so powerfully on various platforms and in this article as well, how policy, when it's misaligned, shows up in patients, whether it's in dialysis clinics or with your patients juggling multiple comorbidities that they have, whether it's access challenges and others. Can you share some example of that disruption and what this means in terms of true biological alignment, what it would look like if true biological alignment was to be followed instead?
Yes. So in dealing with patients, first off, all patients don't look the same and all patients are not equally affected. So specifically Black patients, patients of color, minoritized patients are the ones who are more affected. So when you think about patients on dialysis, even though Black people make up only about 13% of the population, we make up 35% of the people on dialysis. And when it comes to phosphorus, we know that over 70% of our dialysis patients have issues with phosphorus, and they really do need effective ways to lower the phosphorus. The other issue is access, right? Access to foods. Even though we counsel our patients to take in low amounts of phosphorus, the reality is that if you are on a fixed income, or if you live in a food desert, if you simply don't have access to all of the fresh foods, then oftentimes you're eating processed foods which have phosphorus. And so if you're one of these patients who is in a minoritized group, if you have a lower socioeconomic status, then it is so important that you have the proper access to the best of the best when it comes to phosphate lowering therapies. Now, when you're talking about medications that are in the bundle or medications that are only given when a patient is in dialysis, that completely goes against the biology of phosphorus, because our patients, our dialysis patients, are taking in the phosphorus when they're home, when they're eating. Patients aren't even allowed to eat on the machine. And so it just really is counterintuitive. It doesn't make sense. And even with some of the old phosphate lowering therapies, a lot of them required patients to take 5 and 6 pills at every meal and carry the pills in their pockets and do all of these things. Now, finally, we have access or the possibility of having a simpler way to lower phosphorus. And we know it's been proven in trials that it's very effective. Yet, with the way these things are set up in the bundle, patients don't have access. So bottom line, what's happening is not only is the bundle going against the biology and the natural order of things, but it's disproportionately affecting the patients who need it the most. It's actually doing harm to our patients, which of course is not what should be happening.
Thank you, Dr. Farida. So you've clearly outlined how this biology, when it's ignored, at least in this case, the ESRD payment bundle impacts patients. In terms of the denial of access of some of these innovative therapies or exposure, in this case for phosphate lowering therapies, how does that prevent restoring biological order for some of your patients? And what's the impact to individuals who need this therapy and are not getting it?
Oh gosh, the impact is huge. I'm sitting there watching my patients who have tried all kinds of different phosphate lowering therapies in the past, and some of the therapies just aren't effective. Some of the therapies have debilitating side effects. Some of the therapies just require so much of an inconvenience in having to carry so many pills around that patients being compliant just really is not realistic. And so I'm sitting here trying all of the old medicines that have failed patients in the past. And even though I know that there's new technology that will help my patients to do better as far as having a low and healthy level of phosphorus, I'm having to sit there and still give them a lot of the same old medicines instead of moving forward with the times and taking advantage of the new. So this is what I'm seeing. I'm seeing that my patients are having literal physical consequences when the phosphorus is not properly controlled, because we know that it takes properly functioning kidneys to filter out phosphorus. Well, of course, patients who are on dialysis with kidney failure, well, they don't have the ability to filter out phosphorus properly. And in many cases, even when they try to limit their phosphorus, the phosphorus is still high. And so here are some of the consequences. When the phosphorus is too high, it can cause an elevation in PTH, parathyroid hormone. That can lead to disease of the bones. It causes calcium to be pulled from the bones, and it puts patients at a higher risk for fractures. And you can imagine a lot of dialysis patients right after treatments might be a little lightheaded sometimes, have blood pressure that's a little low. So if you combine that with a patient who has poor phosphorus, poorly controlled PTH, and they fall, well, now you're putting patients at risk for hip fractures. Ask me how I know. I've seen it. Also, it can increase their risk for heart disease, for vascular disease, because when the phosphorus is not properly controlled, it can bind with calcium, it can become sticky inside of the vessels, and it can cause poor circulation and increase the risk for heart disease, heart attacks, amputations. Ask me how I know. I've seen it. And that's why when I first learned about the different studies being done with some of the newer phosphate lowering therapies, the ones that don't require you to have to take 5 and 6 pills 3-4 times a day, I was like, oh my gosh, now patients can just take pills twice a day. That's very doable. I've been very excited, but it's really disheartening to sit here and watch patients in my dialysis unit not even have the access when I know that they can. And that is why I've been, really excited to be a part of this discussion and to write this article, because a great part of me is an optimist. And I'm just like, maybe people just don't get it. And so if we keep ringing the bell, keep explaining, then I'm really hoping that common sense will prevail and will make these medications more accessible.
Coming to you now, Dr. Desir, what are you seeing in your clinical experience that reflects these violations of biological order and principles?
Well, thank you to Kelelaye for the invitation to participate with part of this esteemed panel. I think as an extension of what Dr. Puckrein was just commenting on, it would be a transition of how do you go from policy to a health-related social need outcome or adversity, which is what I think the extension of what we're seeing in the clinical world. In the management of end-stage renal disease, the nephrology team, which is composed not just of the doctor, but also of nutritionists, social workers, nurses, technicians, and such, have a certain degree of have certain parameters, I should say, that we look at for every single patient that we need to make sure is compliant, or what we would say at goal. And so in looking at the bundle, we are restricted in the medication options that we can offer. And not only that, to the tolerance of how the patient does with these restricted medications. When you think about it from how is this ultimately causing policy to affect essentially the management of medicine, you're essentially limiting the toolkit that the nephrology team has for the management of these conditions. And what we don't account for, which I think the article very nicely lays out, is how does the environmental situation of each individual patient lead into the ability to have positive health outcomes? Your community dictates your environment in terms of the access that you have for food, the access you have for transportation to and from your doctor's visits, and also the ease of which to get to the dialysis unit. Your housing might dictate the kind of dialysis options that we are offering to you. Your employment is going to dictate essentially your insurance status, which we did say Medicare is covered by the government, but you have other chronic conditions that also need to be managed that would be influencing your end-stage renal disease. So what is your ability and your knowledge and your awareness of what's going on with you physically? How does that impact essentially what we do to manage your chronic kidney disease, or rather end-stage renal disease? So I think the short of the answer is it's a hindrance, it's a barrier, it's a limitation. The outcome and the adversity of that is lack of optimal care for patients. So they're not optimally hitting all of the metrics expected that we would want in the dialysis unit. I would say in particular, particularly with the new rule of having, oral phosphate binders, with the limitation of only being able to prescribe that in dialysis units. What we see is an inability for the centers to actually house all of the medications that really we need for the variety of what patients can tolerate. A lack of tolerance based on the limited samples, or I should say options that we do have from patients, because it's not a one size all fits flavor. And then with that said comes lack of compliance. When you're sending the patient home with something that they're not really responding well to, then the easy thing to do is to stop taking it. So now you're seeing adversities in the blood work. And what I've also personally just noticed myself is an increased number of complications related to mineral bone disease now occurring more in the hospital, because it was better managed when we had a little bit more control over what we were prescribing to patients. Now what I'm seeing is more people coming in with conditions called calciphylaxis, which is a skin condition as a consequence of imbalance of calcium and phosphorus, but it's really, really traced back to lack of compliance or tolerance of the binder that they're taking. Increased fractures, because it's also a complication that can occur when mineral bone disease is not in balance. And even with anemia management, though that is not probably at the forefront of what's happening, I would say, in terms of limitations of the bundle, we are also starting to see too that different centers, different hospitals have access to different meds. And so some patients are more resistant than others, depending on what your option is as well. So you're seeing some variability in that. And ultimately what this does is increase admissions to the hospital, increased utilization of the ER, prolonged hospital stays. And so what does that mean? Increased morbidity and mortality, increased people getting sick, increased people dying. So it's been a limited time, so to say, in the world of policy that maybe this has been implemented. In the world of clinical management, it's enough to see that there has been adversity, there has been challenge, and it continues to get worse, not better.
Wow. Thank you. This is a great understanding from the front lines, really where the rubber meets the road in terms of how policy-induced biological disorder impacts your patients. I wonder, where do you see even more clearly the biology being ignored with this specific ESRD payment model? And if you would elaborate on that.
I recognize the challenge of those who implement policy, and with that said, who maybe don't feel the actual physical manifestations or consequences of the rules that they create and what it means to others. But I think that the stats speak for themselves. As a clinician who's not only involved in clinical work, but who's also involved in the area of policy, I have the opportunity to see documentation across the United States. And I think the one patient that's probably pretty common to all hospital systems is the dialysis patient. And what I find is when we talk about those with kidney disease, we are aware that those who are Black and brown have increased risk. We understand that those who live in certain communities, particularly maybe urban communities, may be more at risk. What we don't fully appreciate, though, is that the rural patient is also a challenge, right? The patient with multiple comorbidities is also a challenge. The youth, because growing up, essentially, I feel like an environment where food and nutrition is an issue and a barrier, are growing up with earlier onset of kidney disease. So when we talk about the impasse between biology and what that means for policy, I think the impact, the idea that 75% of people have essentially end stage renal disease from a secondary condition like diabetes and hypertension speaks for itself. That is policy that allows the food that we have access to, the communities and the diligence and effort put into healthcare is really essentially made by government in terms of guiding what the rules should be. So I think the proof is in the pudding. It's kind of striking to me that, the government essentially intervened to support dialysis, really with an effort to try and diminish the incidence of it. And really with its efforts, it is actually, intensified the number of people who actually suffer from this chronic illness, and more so from things that are preventable. So it's really a lot to what Dr. Puckrein says. There needs to be a shift where, if policy intends to work in collaboration with medicine, understanding and awareness of the implications of what these decisions do to physical laws is critically important to kind of shift in a more kind of holistic and comprehensive direction of better balanced care.
Yeah, and you see this lived biology every day in your practice. And going back to this ESRD bundle payment, and in terms of the policy, how does it restrict your ability to deliver optimal care as far as these patients that you're seeing, especially those facing the higher disease burden and some of the challenges with comorbidities?
Ultimately it's restrictive because it doesn't allow the clinician to choose what is the best option for the patient. It limits the clinician by the options available as guided per the center. And that's not really, to me, well balanced medicine. Nephrologists often will go to more than one dialysis center. And though those centers may be have a lot of commonalities. Some of them might have distinctions in terms of what the options are that we can offer for phosphate binders. What is the on formulary, or essentially the standard of which what the center wants to use for anemia management? What are some options that we use to balance what we call mineral bone disease? So for calcium and phosphorus balance that are separate from the binders that we give to the patients. So when you're having to essentially make your decision based on what a center offers versus what you think is first line and best for your patient, that's not the way we were trained to practice our medicine. We were trained to do no harm. We were trained to do what was of the best and kind of highest benefit to the patient. And it really kind of puts more business in top of mind versus patient as top of mind. So I would say the limitations exist in not being able to maybe optimally care for patients in the way that I would choose to, based on the restriction of what is guided to me by the dialysis center.
Thank you, Dr. Desir. Let me bring you back in, Dr. Puckrein. This article implies that the current healthcare system doesn't adequately address biological disorder. And that impact is felt even more in historically under-resourced and underserved communities. So what would a payment system designed with physical laws framework in mind look like? Or what would that look like in terms of this ESRD bundle payment?
So where we should start and what everyone should think about, you have 3 trillion cells in your body. They are talking to each other, collaborating with each other all your life. And most of what they're doing, you have no control over. Your kidneys function, you're not thinking about them, they're managing in really precise ways the management of phosphate and calcium and other minerals in your body to keep you healthy. When we start talking about end stage renal disease, we're talking about the kidney having lost that capability. And it takes a lot of attention and resources and intervention in order to do what that kidney was doing. And so if we really want to deliver quality healthcare, we have to follow the rules that the kidney is demanding, quite honestly. And it's not like, you can get 5 guys in a room, come up with a health policy that says that we don't need to follow those rules because we don't think we have the capacity. The American healthcare system spends $4.5 trillion a year on healthcare. That's larger than the GDP of France. It's larger than the GDP of Germany. And so we think we have the capacity financially to make quality care available. And as you're hearing from the nephrologists on the panel, they're making decisions that are being dictated by financial and policy models. And we can no longer do that if we want to provide quality health care to every American. And that is the transition. And what we should understand is the reason why we're in this moment is because we've gotten smarter. We've gotten a lot smarter. And we're going to get even more wisdom about how to manage our bodies collectively. There are going to be wearables and AI and a whole lot of stuff coming down the pipe. And we can no longer have our healthcare policy and financing living in the 20th century or maybe even the 19th century in the way in which they're thinking about their role in the delivery of healthcare. They are obliged to follow the science, as are the physicists and the biologists and the chemists and the nurses and everybody in the system, including members of Congress and state legislators. They can't rewrite those rules. There's no court in the land that can abrogate what's going on with our biology. And so that is really our future. But again, I just want to underscore the freedoms that will come to us as we embrace what are these immutable laws, meaning we'll get smarter about how to manage renal failure or keep people from renal failure. And those are the investments we're making, and that's our future. And we need to embrace it. And certainly what we're trying to say in that Health Affairs series is that the future is now, that we cannot ignore what science is teaching us in terms of how to keep ourselves and our communities and our friends and our neighbors and our children healthy.
Thank you. And on that note, what can people do, whether they're physicians or healthcare professionals, caregivers, or patients, to make sure that this system and the policies that are being passed are prioritizing their best and well-being versus cost or any other thing that's being prioritized at the moment?
We have to do what we're doing right now. We have to advocate. We have to tell the story. I would bet that most of the members of Congress who are not physicians, certainly, or scientists, don't know anything about these physical laws. They're running around writing healthcare policy and financing, but they have no idea about these physical laws. In fact, when you say physical laws to them, they probably think it's all complicated mess, and why do I have to pay attention to it? And I would say that to the patients. The patients may not know the decisions that are being made about their lives because nobody's telling them that. And so the advocacy to the payers, I think, and the managers of dialysis centers, they need to be part of this conversation. This is not about changing shareholder value. This is making sure that you have the resources and ability to provide the care that those who come into your centers are asking you to do for them. And so I think there's partnerships all over the place that can realign how we're spending our money and resources and paying for real value. And that real value is really patient outcome.
Absolutely. And the final questions to each of you: what gives you hope in terms of what we can how we can re-engineer the systems so that it's focused on patients and it's focused on the biology and the science to conserve life, not really go against or disrupt it? And then what gives you cause for concern? So what gives you hope and what gives you cause for concern?
It's a very good question. I mean, I will say for myself, I think this dialogue gives me hope. It can be heavy to see patient after patient and feel like you know that things need to change, but they're not actually changing. And so I think part of that is the realization of like-minded people who are part of that movement in kind of fostering the change. That's what instigates the wave, where more people come along and you actually start to see the shift in the movement. So I think, like Dr. Puckrein said, the time is now and it's happening. So that absolutely gives me hope. What gives me pause is how many people have to suffer in the journey as we move towards that change. There are those who will not be able to kind of reap the rewards of the success of this movement, but they are no less important and no less significant in our advocacy, in our work. And so sometimes it's hard. There are definitely patients in my mind that I think of to this day who, had it been a different circumstance, there would have been more sustainability of life. But it's also what drives the passion of this work, to say that that experience informs me and the space and being here with all of you to advocate for that needed change.
Obviously, what gives me tremendous hope are physicians like Dr. Desir and Dr. Fisher, who know a lot more about the kidney than Gary Puckrein would ever know. And really what we want to do is help them operate at the top of their license, because their deep understanding of how to sustain lives and make sure that kidneys are functioning appropriately, even for those who are impaired, is mind blowing. I mean, I can look back historically and tell you that physicians in the past didn't even have that knowledge. You know, we can go back pre-germ theory. They didn't even know about bacteria and whatever. So the moment that we're living in is just amazing, and it is distinguishable from the past. And so I just have tremendous confidence, and certainly in the researchers and the ongoing fight that I think will bring us to a whole different future that past generations could not even begin to imagine. And I'm excited that that window is opened up. I may not see into that future or live into that future, but the pathway is open, and that's absolutely exciting. I think, change is challenging. It is the kind of system changes that are needed are not going to happen overnight. And there will be lots of those who want to maintain the status quo for a whole host of reasons, and we have to persuade them that letting go and helping us reimagine what that future is will bring the most be most gratifying for them. And it is part of what the democratic experience is about, which is to persuade others that on this journey collectively we can do just really incredible, wonderful things. So I look at the journey in front of us and realize that it's not inevitable, that there will be deep struggles along the way. I am incredibly optimistic that as we come to understand what our future potential is, that we will embrace it. And for those right now who are on dialysis, we need to take our best effort and make sure we're giving them the quality of life that we're capable of doing.
I'll tell you, with a lot of things that are going on, even beyond the phosphate lowering therapies and the bundle, my optimism has been tested. I'll tell you the truth, but I just have to believe that the nature of all mankind is good. And I have to believe that if we keep presenting the data as we've done, and we're showing that certain policies are causing harm in communities that are already underserved, I just hope that the conscious of people that will weigh in. And when we see that the benefits of how we're preventing, the benefits of how we are presenting ways to give patients access to medications, we're only helping patients, we're not causing any harm. And so I just have to be an optimist, or else, things will be real, grim to think that people, policymakers, lawmakers, I just can't believe that they would intentionally put policies in place to harm the least of us. And if that's the case, I'm going to find out, because I'm going to keep ringing the bell. I'm going to keep shouting from the mountaintop with other people who, share the same beliefs, that we are here for the benefits of our patients. And it is our duty to help the least of those with the least access, to make sure that they're not being underserved any further than they already are.
That's powerful. Last word on what can we do to make sure patients' voice are heard, and policies, whether they're financial or otherwise, are prioritizing patients and the quality of care versus costs or anything else?
Well, knowledge is power. And so, yes, many of us who are healthcare providers, those of us who are in politics, those of us who are familiar with policy, we are gaining this knowledge. But for me, it's talking to the patients who are actually being affected. These patients, my dialysis patients, many dialysis patients, don't even know of some of the newer technologies, the innovative ways to lower phosphorus, because it hasn't been introduced to them. And so I have literally been telling my patients about what could potentially be available, not to be mean and be like, nanny, nanny, boo, boo, this is something that could help you and you don't get it, but just to make them aware, because I believe that there is power in the patient. And so spreading the knowledge, not only among those of us who are able to go to DC and who have the loud voices and the microphones, but also talking to the patients who are able to write an email, grab a pen and paper. I'm encouraging people to talk to their local lawmakers and just really just flood the information system and try to make better policies to help patients to have this proper new innovation in phosphate lowering therapies, and so that these patients are no longer at the highest risk of all of the complications from having poorly controlled phosphorus.
Dr. Desir, any final words of wisdom or final thought from you?
I keep up the good work, really. I think ultimately it's conversations like this that are going to move the needle, particularly with our ESRD population. And to Dr. Puckrein's point, there are those actively on dialysis, but there's a litany of those that are not far, from actually adding to that total number. So I think it's everything that we're doing now is ultimately not just to advocate for those on dialysis. I think sometimes in our dialogue, we focus on the most vulnerable, which of course is this subgroup, but it's also to prevent. I think there's a big part of that is conversation is how are we not only thinking about supporting those who are already end stage, but being more diligently preventative to diminish the number of those who are end stage? How do we advocate for those who are end stage, essentially for the opportunity for transplantation? So though this conversation is important and absolutely focused on the bundle itself, it is a much broader conversation about this population. How can we be better advocates to help those better live with kidney disease and maybe, shift the numbers about where we are now to be something that's better in the future?
Well, thank you, Dr. Desir. And that's exactly it. As we wrap up, the message we want you all to carry forward is that this isn't just a policy conversation. It's not theoretical either. It's urgent and it's based on science. And when healthcare finances violates this biology, the most vulnerable are often the ones that pay the highest price. But when we align policy with nature's laws, as was discussed here, that we know govern the lives of patients and survival, we can build systems that truly conserve life. So here's a few asks that we have of you all. How can you take action? You could, first of all, read the Health Affairs article I pulled up and shared with you all earlier. It's also going to be in the comment section. You can find the link below. We want you all to engage, comment, challenge us, participate in this discussion, be part of it. We also, if you'd like to learn more, there's a website, conservelife.org. So that's conservelife.org, where you can learn more. We also have designed a voter voice tool, a way for you to send a message directly to policymakers urging CMS to reform the ESRD bundle and align payments with biology, as we talked about here. So thank you again for being a part of this important and enlightened discussion. Thank you to my guests, and we look forward to continuing to work together. Thank you.